good luck. Um, so as Jean mentioned, I work at Cincinnati Children's. I work with Dr. Myers and Dr. Koo. Um, I'm a pediatric dentist, and my kind of career has been centered really on treating patients with special needs. Patients, one of my challenges, one of the things I've always tried to dedicate myself to is giving access to patients who have difficulty with access. And I know that any patient, adult or child, that has any kind of a special need have a lot of difficulty finding providers in the community because they'll say, well, I don't feel comfortable with that. And that can be really frustrating and challenging. So my dental training was in New York at NYU. I'm from Southern California, did all my undergraduate, everything, lived at home during college. So when it came to applying to dental school, my only criteria was it had to be outside of California. So I literally said, okay, I'm going to go to New York, as far away, which, as the firstborn in an Indian family, essentially, and my mother still gives me guilt trips to this day that I broke her heart by leaving, and she got over it. So um, did my dental training in New York. Then my last 2 years joined the Air Force, and the Air Force paid for my last 2 years of dental school. So I was in the Air Force active duty for 8 years. I did a general dentistry residency for just up the road in Dayton at Wright-Patterson Air Force Base, and then went to Cheyenne, Wyoming, and lived there for 2 years as a general dentist. My dad joke is I was the Indian in a town of cowboys. So, and I say that every time, and my residents and students who hear it every time, oh, they kind of roll their eyes and everything. But uh, Wyoming for 2 years, then came back to Columbus, did my pediatric training at Ohio State, and then fulfilled my Air Force payback with 3 years in Germany. And Germany was wonderful, very different international standards for oral care. Lived in Germany for 3 years, was offered a teaching position back at Ohio State for 7 years, and then I've been here at Cincinnati for 13. And my time here, I was the director of dentistry at the hospital. And a few years back, so a lot of my work, as I've mentioned, has been with our oncology patients, hematology patients, and then a group that called epidermolysis bullosa, which is a condition, it's a skin condition. These kids get a lot of blisters and ulcers. So if you touch their skin, they will blister. So you can imagine their mouth is very challenging. So I've worked with these populations for over a decade, and the bone marrow team here came to me and said, we would like to hire you as one of our folks. So I now spend a day a week of my time with the bone marrow team, and I work with kids in all different phases of chemotherapy, radiation therapy. And that's where my interaction with Dr. Myers and Dr. Koo came in. We are doing research and clinical trials looking at patients with bone marrow failure conditions, so Fanconi anemia, neutropenic conditions as well. So that's kind of some of my clinical background. I'm married. I have a son. He's 23. We have 4 dogs. My sole dog is a 11-year-old greyhound. His name's Oliver, and he's like the best thing of my day when I come home. He's just there, these like mournful eyes, and just like, love me. But I can't understate how important groups like this are, because, and I'm sure you've heard this recurring theme, it's so easy to feel alone when there are conditions like this. As I mentioned, my son's 23. He went to UC for college. He was born with severe food allergies that we did not realize until he was 6 months old. Milk, wheat, egg, peanut, tree nut, soy, garlic, sesame, barley. Um, we found out because at 6 months of age, he had an anaphylactic reaction, had to get an EpiPen, had to go to the hospital. I mean, we thought we were going to lose him. It was easily the worst day of our lives. He had subsequently two more of these reactions um, to different things. One was to curry. All he did was he went up to, my wife was cooking, and he went up to the spice mix and he inhaled it, wanted to smell it, and it triggered a reaction. So we were fortunate in that we found an amazing allergist. And when I say amazing, he was clinically very smart and bright, but he knew how to talk to us like parents, which I think is a huge skill that not a lot of physicians have. And I have learned over the years from talking to parents how to address issues and concerns. So a lot of my experience comes from, I mean, I'll ask parents, I'll be like, tell me, like, what do you do? And I'll ask patients, how do you feel like if I do this? Because that's how I learn, so I can tell people. Dental care is very challenging. Number one, finding someone who can treat kids is very challenging because a lot of general dentists don't feel comfortable. We want kids to be seen at age 1 at the latest. So we want kids to be seen very young. Now, in kids who have chronic neutropenic deficiencies or cyclic neutropenia issues, where we see that a lot of times my first exposure is kids who have unusually loose teeth early on. So these are like 2-year-olds, 18 months old, who come to us and their teeth are loose. And we have kids who spontaneously lose teeth. So they lose a baby tooth at 2.5 years old. And what's different than in the other presentations is the tooth comes out completely clean. It doesn't have anything on it. It's just like it was a museum exhibit or something, just totally clean. So this starts leading us down different roads, and there are conditions: hypophosphatasia, Chidia-Kagashi, Papillon-Lefay, all these fancy words, but there are conditions that we start looking at. So this is why we want to see these kids very early, because we want to be able to prepare the parents for how to deal with issues their children may have. When we have cyclic neutropenia, some of these specific issues are going to be not tooth-based, but gum-based. So your tooth is held in the bone by little ligaments and little fibers, and those fibers and ligaments can have problems related to neutrophil levels. And so teeth can become looser than usual. They can get what are called periodontal gum defects. So sometimes we'll have kids who have to have gum surgery at a much earlier age to preserve their teeth. Now, the other piece, and I'm going to talk to the parents in here, is I can tell you this as a parent who has a child with special needs. He's 23. He doesn't like it when I come up and give him a hug. He does he does this, rolls his eyes, but he's still my little guy. We tend to indulge kids who have special needs because they are going through some type of medical condition. We overindulge them. Usually that is a food-based reward system for parenting, where if the kid does something good, we give them a treat. And so we do know that kids with special needs can sometimes have much higher sugar exposures than kids who don't have a special need. Additionally, these kids are very often on medications that we need them to take. And we need these medications so that we need compliance. As a result, you'll find many of these medications are very high in sugar. So some of the cardiac medications can be as high as 30% sucrose, sugar. So what parents will do a lot of times is they'll give that medication right before bed. And so one base message is if we have a chronic medication that we're typically giving that about 30 minutes before bedtime. And the last thing we're doing is we're doing brushing and then going to bed. Um, so then as we get into later years, we start developing things related to mouth ulcers. And then we get questions about braces and orthodontics and aligners. Can these be used in patients who have neutrophil defects? They can be used. Now, one thing is that there is a relationship between neutrophils and bone turnover. So if I have someone that did not have any kind of a condition and braces would take them 24 months, it might take my patient with neutropenia 36 months. Because there are two things here. One, the movement of the tooth within the bone may be slower. And two, we want to use less force on the teeth, because the more force we're putting on the teeth, the more we could trigger some of these gum defects, bone defects that could end up to compromised teeth. So yes, you can absolutely have braces and aligners. And there's no evidence on aligners. I mean, this is really kind of a new thing, and this is Invisalign, the kind of clear retainers that are used to move teeth. Used to be that those were only done to move like one tooth. Now those are done to do jaw movements, expand the palate. So we're really in a kind of very new age of how we move teeth. And then there's mouth ulcers. So mouth ulcers are really, for a lot of these patients, your children, the bane of kind of oral existence is getting regular mouth ulcers. How do I manage those mouth ulcers? Now, in some cases, what I have seen is folks will be prescribed what's called magic mouthwash. And magic mouthwash is a combination of lidocaine, which is supposed to numb the area. Typically, there's something like Benadryl, and then there's Maalox. And the three of those are used together. Now, one of the things with magic mouthwash, and I'll tell you right off the bat, no disclosures here, no financial relationships. The Maalox people have not gotten to me, but I will tell you right off the bat that I'm not a fan of magic mouthwash. And the reason for kids, and the reason is that it takes a contact time of about 2 minutes for magic mouthwash to be effective. So you imagine me giving you this and you 2 minutes. That's tough for an adult, much less for a 7 or 8-year-old. So because that contact time is such a requirement to be really effective, I'm less prone to do that. I am more prone to just ask them to use Maalox over the counter if it's minor. And what the Maalox is doing is it's basically coating the oral mucosa so that we can eat and it's not painful. It doesn't do anything to reverse the actual ulcers. Now, some of the other medications that can be used, and I'll defer to my physician friends as well here. One that I've used is a steroid, which is called clobetasol. It's a very strong steroid, but it's interesting because it can help that healing. And this brings me to another point. Now, I was talking to Raj earlier and I was mentioning this, which is the most important thing that you can do for dental care is get the name of your dentist, get a card, give that to your physician. Get the name of your physician, get a card, give that to your dentist. Those two need to be talking on a regular basis. I can tell you when I work with Dr. Myers and Dr. Koo, we are emailing or texting about patients pretty continuously. Especially when patients come up, tongue sores, tongue ulcers, which is, I mean, that's like the worst because we don't realize how often our tongue is moving. If we were just sitting there, our tongue is still moving. And so it can be exquisitely painful. So, so regularly having your dental office and your primary physician talking is probably the most important thing to make your care, your child's care, smooth and consistent. Because the problem is when they're not talking and there are different things. So I just mentioned clobetasol, which is a pretty strong steroid. Now, clobetasol, the recommendation is typically not being used for more than about 10 to 14 days. So it's got to rise to a pretty significant level of life impact for me to even suggest that. I'm suggesting that not to the parent, I'm suggesting that to the physician. So I'm calling the physician saying, hey, Johnny came in today, had these pretty significant ulcers in his mouth. I would you consider this? So ultimately, I am not the one prescribing it. I'm letting the physician manage it, but some physicians may not be as aware of that as a medication. The other medication that I use, and this is from my experience with my epidermolysis bullosa kids, is called Carafate, Carafate. Um, that's the brand name. The generic is sucralfate, Sucralfate. Now, what's interesting about Carafate, it is classified as an antacid, but it doesn't really do antacid type of things. But it functions a little bit stronger than Maalox to coat the oral mucosa, and it stays around longer than the Maalox. And so it can provide more immediate relief. Typically, if I'm recommending that, again, I'm still talking to the physician, but I'm usually saying meal times and at bedtime or nap time so that the child can sleep uninterrupted and can eat. Nutrition and hydration can be really challenging when there are oral ulcers. And I did get the questions. Jane gave me the questions, so I'm going through them as well. One of the other questions was talking about enamel hypoplasia. So what that is while teeth are developing, there's enamel, which is the white hard part we see, and underneath that there's dentin, which is yellow and soft. Well, that enamel is forming while we are in utero, and your grown-up teeth are forming the minute you're born. If we have children that are going through significant illness early on, the way that enamel is formed is affected. And so what you'll see is almost a pitting. So it looks like these yellow spots everywhere on the teeth. And that's because the enamel did not completely form. So one, that makes that child more or easier to get a cavity because food can get in there. Two, for child, teen, and adult, it makes getting numb more difficult. And we have evidence that enamel hypoplasia has more difficulty getting anesthesia. So these individuals are sometimes extremely sensitive. They breathe in and it's just like, it just drives them up the wall. So in those cases, we may take teeth and instead of doing fillings, we may do caps. And these caps cover the whole tooth to prevent that. Now in baby teeth, we a lot of times will do stainless steel silver caps in the back. There are options now which are called zirconia, which is white. You can do white in the back. It just depends on your dentist, but you can ask about that. Typically, if we're doing anything in the front, we're doing white. So, but I have patients where we will prophylactically, preventively cap all their back teeth because of this hypoplasia. Basically, try to minimize the impact of mouth pain on them eating and growing. The worst case scenario for us is we have a child who's getting such regular ulcers or oral issues that their oral ability to eat goes down. And then these kids need to be potentially worked up for feeding tubes. And we don't want that. So we might preventively cap these teeth for that reason. I'm going to stop there real quick, and I've talked about a lot already, and I want to take any questions about what I have talked about so far. Yes. Mm. Absolutely. Absolutely. I mean, I described it as this kind of pitting, but it's not always like that. Sometimes it can be exactly what you described, which is so children, for the most part, grind their teeth. That is a normal um, reaction in children. And that has to do with muscle maturity. And it's almost like twitches in the muscles and their jaws are moving. It is very uncommon that kids who grind their teeth become adults who grind their teeth. Adult tooth grinding and teen tooth grinding is much more based in stress and kind of neurological issues. Young child tooth grinding is based on typically changing sleep habits. Um, Interestingly, kids who have a history of recurrent ear infections are more prone to demonstrate tooth grinding. And the reason for this is if you think about it, if you're in a plane and everything feels all stuffed up, you move your jaw and then it pops. Some kids develop that, as a reflex. If I do that, if I do this, it like pops my ear and they feel better. So some kids habitually develop this. I remember my son, and he never had ear infections, but we'd be in the other room and it would literally sound like he was gargling with rocks. Like he'd put rocks in his mouth. He's like, "Arr." And I would literally, as a dentist, I would take my flashlight and I would, while he was sleeping, I'm like, what are you doing? Like, what is going on? And he wasn't, we didn't have any damage to teeth or anything like that, which I was amazed at. But that was just his normal response. Now, in your son, as an example, which is great, if there are no obvious cavities, someone who's breaking teeth from tooth grinding is typically telling us that there's something going on. That's either an enamel deficiency or there's something just, something that is not normal because most kids can grind their teeth and not break their teeth. Yeah. Does that answer your question? Yeah. Yeah. Yes, sir. So, the American Academy of Pediatric Dentistry, which is aapd.org, has if you scroll down the landing page, there is a find a dentist page where you put in your zip code and a radius, and it gives you a list of providers. Now, pediatric dentists are more likely to have treated children in a hospital setting. So we're more likely to have come across various aspects of neutropenia. So I think that is a good place to start. Um, and then reaching out to those offices in your area. Um, Jean has my email, and you can share my email with everyone. You can email me and just say, hey, I'm a parent. I met you at the neutropenic talk. Um, Here's where I am. And if I know someone, or if I have one of my former residents who's in your area, I'm happy to share that. So that would be the place to start. Any other questions right now? Good. Yeah. Yeah, absolutely. Yeah. No, and that's a really good question, because so the idea is bacteria from the mouth can get into your blood, and that can lead to bad things. So one of the best strategies is if that child is brushing regularly, because every time we brush our teeth, we have a bacteremia. Bacteria goes into the blood, but it's a very small amount. Typically, the bacteria is that amount is within 30 minutes of the insult. So if your child has splenectomy and is in any way classified as immune compromised, absolutely, antibiotics I think is completely legitimate. Now, there are visits where we can. So if I'm seeing a younger child, I might, instead of doing, we have the rubber cup that they use to clean teeth. Well, we know that with kids and baby teeth, we can do what's called a toothbrush prophy, which essentially is a professional toothbrushing and then fluoride, and it is as effective. In fact, the more important part of that visit is the fluoride application than the actual cleaning with the thing. But that makes us all feel better. It's the same for me. When you're an adult, you want, like my wife will go to the dentist and she'll be like, "Oh, it was a really good visit." And I'm like, I'm just curious, like, why was it good? And she's like, oh, I could hear the scraping. I'm like, you've got mental issues. I don't know what but yes, I mean, we kind of get into these habits of this is what equals a good visit. Um, so it just depends on what's being done. Now, when we get into the teen years, we are more likely to have tartar buildup, where we have to go in and scale that off. So I'm more concerned about it in the teen years than I am if this was a 3 or 4 year old. And in fact, when I talk with the physicians, I will say, well, we can probably forego the antibiotics for this kid who's 5 or 6 and just reduce their exposure to that antibiotic, and then use it when they're older and we need it because they're getting more grown-up teeth. Does that make sense? Yeah. Mhm. And there is something to be said for, and I'm really happy to hear that you have a dentist who's kind of aware in that sense, because um, it might be easier to do more fillings at one time, but we are overloading an immune system that isn't at full function. So doing this in short insults to the immune system is probably a more prudent way to do it. Yeah. So what the way I would put this is, if this was my son, one, I would want the wisdom teeth removed in a hospital setting, not in an office setting. I would potentially be talking to the surgeon about admission after, not necessarily because I'm worried about an infection, but what I'm worried about is pain control and hydration. Because it just, I mean, wisdom teeth can come out very easily, but they can also be very challenging. Um, the other thing I think is I would, if you have a surgeon who's telling you these wisdom teeth need to come out, I think it's totally reasonable to press them and say, why? Like, what are you seeing that's making you think these need to come out? And two, going back to what you had kind of mentioned with your previous comment, do I need to take all four out now? Can I just take two out? Can I do one side and come back a year later and do the other side? And this is going to be individual discussion based on your child's healing ability. And I would definitely loop in your physician into that discussion. Same thing, which is, okay, what's our post-op plan? Because sometimes we have the easy part. We just go in and do the work, and then you've got to manage them at home, which includes their diet, pain control, all of that. So, um, yeah, so I would do it in a hospital. So that by virtue means that I have a surgeon who has hospital privileges. And then I would ask why they need to come out. And then do we need to do all four at the same time? Can we just do select? Yes. Yeah. So it's interesting. Again, this is in our mentality. The 6 month cleaning schedule and all that was dictated by insurance companies. That's not. There's no evidence that 6 months is like the ideal time. So we try to take an individualized approach where some kids were saying, we need you every 3 months because you're either at higher risk or you do more, you have more tartar buildup or whatever reason. But then I also will have other kids where I'm like, you're okay for every 10 months. You don't have to come because you're doing such an amazing job. And if you feel you need to come earlier, call and let me know. So it is based on the child's risk, um, their age of development, meaning when we get into that 8 to 10 age frame, kids are losing teeth and getting teeth. So a lot of times, like they come in and they look like a jack-o'-lantern. They don't have a lot of teeth in there. Well, I'm not going to take x-rays at that point. May not need to even do anything beyond a toothbrush cleaning, but I do want them back in when those grown-up teeth are in, and I want to see how tight they're touching, et cetera. Yes. Oh, sorry, go ahead.
because we did need to go to the periodontics. That I didn't. Dad takes them to stuff, and Dad's not the folks when he tells me about things. So like I kind of didn't understand, like how bad it was.
I feel like that's becoming a mom dad thing. So I'm gonna, on the behalf of dads everywhere. Yeah, yeah. Yeah.
Did you know the bone loss, right? Didn't stay on top of it, and so everything that you've been saying was like, oh yeah, like a really properly supported thing that, but being like, oh, he's so healthy.
Yeah.
I mean, kind of.
So one of my advantages, at Children's is after I see the patient, I put a note in and I have a plan. Dr. Myers and Dr. Koo can immediately see my plan and they know exactly, and they will often cut and paste my plan into their overall plan so that it's just part of what this child is getting. So if I was in private practice, I would email whatever my visit note to the physician and just say, hey, saw Johnny today, and here are findings. So that they have, okay, he's doing good and all this. Yeah. Yeah. Yes.
Do you recommend like an increased fluoride treatment schedule for? And I know every patient's different.
Yeah. So what I'm going to base that on is going to be, so for example, some kids, like my son, because of his allergies, he was a grazer and he would just eat throughout the day. And he was, his weight was always on the lower end of the growth curve. So anytime he wanted to eat, he would eat. Other kids, like you have to pin them down and they'll eat maybe twice a day. So as I'm talking to you, I'm going to find this stuff out and that may change things. The other big shift in terms of fluoride really is teen years. When I start losing my, superiority over them, suddenly I am seeing them less than I normally do. A lot of their stuff is out of my sight. Then I might actually prescribe a stronger fluoride toothpaste. It's called Prevident. And we sometimes prescribe that for teens because some teens, and I'm sorry, I don't know, what's your name? Tate. So I'm sorry, Tate. Um, Boys are stinkier than girls. So in my experience, the boys will brush like once a day. And if I can get them that higher concentration fluoride, great. Girls become or seem to be, and I'm very generalizing in a sexist way, girls will be much more attentive to kind of personal appearance. So I don't find that as much. So those are the kind of things that we're going to talk about to make that decision. But I don't just automatically, oh, you have a neutrophil defect, you're getting higher fluoride. Yeah. Yes. Um, so sometimes what happens is the because the gums are sore, we stop brushing. And what that does is actually makes the gums more sore. So then it's a cycle. So what I have done with my younger patients is I will tell the parents to put the toothbrush in a cup of ice water in the fridge. And then when they go to brush, it is so cold, it kind of numbs that area temporarily. And that will, so I mean, ultimately brushing is what's going to help the inflammation around the gums. If it is related to like a neutropenic or neutrophil episode, that's going to have to resolve itself or with the physician, but not brushing is just going to make it actually worse. Yes. Yeah. So I don't have evidence on this. There's no literature out there. But for my patients who have challenges like that, I do recommend an ultrasonic, like a Sonicare toothbrush. So a Sonicare or ultrasonic toothbrush, you are not brushing like this. You are basically holding it in that area. The ultrasonic vibration is getting rid of the plaque. So you don't have to be as, manually brushing as you do with a regular electric toothbrush. So I have had success with that, with my folks who are like on chemotherapy or radiation, who have really just, their mouth is just sensitive. They will tell me it's on fire. They can't do anything with it. That at least will keep it from getting worse. Yeah. Yeah. I would try the ultrasonic just because the technique is different. Um, I personally, I use a Sonicare. That's, yeah. Yep.
So what if is low, he has very sensitive gums. And when we go in for quarterly cleaning, she's like, oh, what's wrong? He's normally not like this. And I'm like, oh, he's kind of low.
Yeah.
One of the recommendations that she gave us is, and he despises magic mouthwash, to put it on a Q-tip and
Yep.
just kind of hold it in those areas.
Yeah, absolutely. That's wonderful. Yeah. Yeah, that's a great recommendation, especially if there are spots that are the problem areas. Yep. Yes, sir. Bum, bum, bum. Yeah. So it's interesting because community water fluoridation has been a big success, and it's a really important tool, but it is just a tool, meaning we're going to look at diet, and quite honestly, toothpaste use is probably more important because I feel like so few people actually drink tap water nowadays. One, kids don't drink water, period. But tap. Okay, well, that's fantastic. What I would say is brushing with the toothpaste, spitting it out, not rinsing it out. So that toothpaste is staying on the teeth. So there is this kind of prolonged fluoride exposure for the teeth. And when I am using toothpaste for kids, anyone 12 and under, you look at these commercials, and the commercials will show this big swoop of toothpaste. I literally take the cap off, run the brush on the thing, and that tiny smear is all I'm using. I'm not using a more significant amount until I get to my older kids, my 10, 11, 12 and up kids. I even don't use that much toothpaste, but I spit and I don't rinse. So yeah. It's going to be it'll be a challenge for a lot of those who don't have immediate access to a dentist. But I think if you're doing that using toothpaste and the other big thing is we did a study here in our dental clinic, and we found that 20% of kids 0 to 3 weren't looking at health history or anything. 20% 0 to 3 had soda in their sippy cups. So for teens and older kids, beverage choice in between meals is huge. You can, and I tell folks, I drink soda, but I will drink it. Like I'm eating, I'll drink it. I don't graze through the day and, have that. I mean, there's medical stuff aside about energy drinks and all that stuff in younger kids. So yeah. Yeah. Acai wasn't even a thing when I was like, is this a new discovery? Because yeah, yeah. Yes. Yep. That's really good. So for my kids who have neutrophil defects, I am doing an annual periodontal probing. So there's a little ruler that we have, tiny, and you guys probably have seen it where they'll put it like in your gums. Well, that gives us measurements. So most of the time our measurements should be 3 and under. That means 3 millimeters, which is like the normal amount. So to your point, because there is this bone turnover and that can affect the bone attachment of the teeth, typically annually or at least every 18 months, I'm doing on those patients a full mouth probing to make sure I'm not missing a problem spot. And at that point, I am reaching out to a periodontist. And I have periodontists that I work with who, again, are comfortable treating patients who might have impaired healing. Because that's really the big thing I mean, the horror stories that I've heard is folks who went to a periodontist, have a neutrophil defect or impaired healing, and that periodontist who wasn't as familiar did a graft or did something more advanced, and the patient just did not heal. And now we've taken a little problem and we've made it a big problem. So I think the point is with patients who have any kind of immune deficiency, neutrophil defects, timing is everything. So we want to optimize. So if I know we're going to be doing that, I'm reaching out to the physicians. Hey, how can we get them to a really good place before we do this? Will a transfusion help? What will help to get them to a really good place? Because I want them to have the best healing possible. Good. Yes. Um, So if the choice is between rinsing with water and mouthwash, I would prefer mouthwash. Ideally, I'd prefer a fluoride mouthwash so that fluoride is staying on the teeth. The difference between adult mouthwash and kids mouthwash is the alcohol. So we typically say kids don't get an alcohol mouthwash because what we know is that age 6 is also, that's what the earliest we even talk about mouthwash is 6. Because if I give you mouthwash before that age, you're going to swallow more than you will spit out. So it's a very small amount. Some parents who are like, well, he doesn't spit well, he has kind of motor issues. So then I'll say, that's fine, just dip the toothbrush in the mouthwash and kind of swab the mouth, and that's totally fine. Um, so where proxil rinse has been really beneficial, and we learned this during COVID, was that it reduces the oral bacterial load. So like if I take someone to the operating room, before I work on them, I actually swab their whole mouth with proxil, except my patients who have any kind of mucosal issues, because I can actually make that worse. So I typically don't. I use something that's more inert. We will use, some of you may know chlorhexidine or Paradex. There is a non-alcoholic version of that called PerioGuard, and I will use that in those patients instead of Proxol. I just fear that I could cause more damage. Yep. Great. So, like I said, Gene has my email. All of you are welcome to email me. No question is silly. My goal is to, if I can answer the question, I will. If I can connect you with someone in your area who can be that guide for you, that's the goal. But what I really want to underscore is make sure the dentist and the physician are talking, because that way there's no crossed wires and mixed messaging. Because I have found when I was earlier in my career, I would say one thing, but then I would hear that the nutritionist or the dietitian was saying something totally different. And I was like, so, I can tell you I'm going to listen to the physician over the dentist. I mean, if it was for my kid and I had no medical training, my physician who's managing my neutropenia is telling me this, that's who I'm listening to. So making sure, so I really want to talk to the physicians and make sure we are on the same page, because most physicians in medical school get 1 hour or less of the mouth. Typically, teeth are what you look past to see the back of the throat. So physicians don't know a lot about teeth. It would be like me, like you come in, you say, I feel I have a cramp, and me going, oh my God, that's appendicitis. I would not make that claim. Likewise, the physicians don't have the training to make a lot of the dental claims. Good. Anything else specific? And I think I answered, yes, answer the questions. Thank you very much.